you've probably been there before. Just as your patient is getting ready to walk out the door from a medical visit with you in clinic, they say, "Hey doc, can you just fill out this form for me for my work?" And there you are, staring at a form that asks you to make estimates of physical functional capacity, and from these estimates, set up appropriate work restrictions. You're already running 10 minutes late, and another patient is waiting for you in the next room. What? I've got no time for this, you think. I've been given no training to write a work restriction, and I don't know the patient's job requirements, and I'm not even getting reimbursed for this anyway. The resulting easy way out? Well, just take the patient off of work, for now, until they see that subspecialist. That'll keep them off your back, and they probably can't be accommodated at work with restrictions anyway. In this article entitled, "How Healthcare Providers Are Contributing to the Iatrogenic Disability Crisis in the U.S., we take our experience with an experiment of embedding a new member of the healthcare team to address these issues, what we call a return-to-work case manager. And much like a social worker or a respiratory therapist or a specialized nurse that has been added to many intensive care unit teams around the country, the concept of using a return-to-work case manager in the outpatient setting was studied in Minnesota and several other states with funding from the Department of Labor and the Social Security Administration within what was called the RETAIN program, standing for Retaining Employment and Talent After Injury or Illness Network. Saddled with increased costs from skyrocketing Social Security disability claims, demonstration projects followed by clinical trials were implemented in RETAIN, looking at ways to mitigate these trends. In Minnesota, we randomized 3,200 patients living and working in the state who encountered an illness or injury that was unrelated to work to either receive support from a return-to-work case manager or simply be given what was considered a control, information about various state-sponsored programs to encourage returning to work. In doing so, we were able to detect significant improvements in getting people back to work safely and more rapidly. In conducting the research, we found that many cases involved providers who felt that they were advocating for their patients, but actually inadvertently contributed to iatrogenic disability. This occurred by any of several means: taking workers out of work completely without a good reason, and by doing so, establishing a sort of new normal for that individual of being away from work. In cases in which patients are taken out of work for longer than 3 months, the rate of returning to work was only 50%. And if an individual remains out of work for a year, the probability of returning to any form of gainful employment drops to less than 10%. We address the most common ways patients are inadvertently hurt by benign neglect. Situations such as the perception that writing work restrictions is outside the scope of practice, so they just don't. Lack of training or time to compose restrictions and complete disability forms. The disappearing patient, in which individuals use inefficiencies of the medical system to delay a disposition and prolong time away from work. Difficult conversations for a healthcare provider to have with the patient. There's situations where there's lack of a provider communication with the employer, so they don't really know what they can do as far as accommodation. And failure to recognize the unintended toll of worklessness and lack of incentives or accountability for keeping patients safely at work in the first place. We look at each of these pitfalls and encourage providers to re-examine their practices and be aware of this unintended consequence of simply taking an individual off of work without a clear endpoint. And just as we wouldn't place someone on opioid analgesics without some form of guardrails, so should be the way we think about work restrictions. And one way to mitigate these issues is by fostering the concept of a return-to-work case manager as a way to serve as a liaison among healthcare providers, employers, employees, and insurance companies. We hope you enjoy reading this article.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.